So TMVR and LV apex PA closure.
Yeah, thank you very much. My apologies for running late. So thanks for this opportunity to talk. I'd like to present a case that we've done here at Columbia University Medical Center about a TMVR case, valve and closure of the left ventricular appendix pseudoaneurysm. Our patient was a 77-year-old lady who's had a prior double valve surgery only 4 years ago. She had a mitral valve replacement with a 25 millimeter BioCore epic valve and a SAVR with a 19 millimeter Magna Ease. She actually presented 3 years later with already class 2 dyspnea and severe mitral regurgitation over bioprosthesis. Now, everyone would agree this is extremely early. She actually presented to another center, was thoroughly investigated for infective endocarditis, which would be one of the first causes for such early valve failure, but nothing was found. Her EF at the time was 65 to 70%. She underwent a planned transeptal mitral valve at the other institution, but unfortunately this was complicated by left ventricular apical wire perforation and tamponade. And from the notes that came across with her, she was converted to an open sternotomy to control the bleeding, and she underwent surgical closure of the left ventricular injury. But she was not placed on pump, and an open mitral valve replacement was not performed. So this was the point that she was referred to us. At this point now, she had NYHA class 3 breathlessness, continued to have severe MR, but fortunately her left ventricular function remained preserved. What was the key new finding, though, was that she now had a new pseudoaneurysm at the apex of the left ventricle, and this measured roughly 25 millimeters in all directions with a 4 millimeter neck. Her STS for redo MVR at this stage was 22%. Here is a CT scan, and I'll draw your attention to the pseudoaneurysm, which is quite obvious here, jutting out the apex. The distance here is 4 millimeters, and then here is a 3D reconstruction volume rendering of the aneurysm. With mitral valve, I know you've had a live case presented today. Here is the snapshot from Vinny Bapat's valve app of the 25 millimeter BioCore epic. And we went on to use a 23 millimeter Sapien Ultra valve. Here is what the valve looks like under X-ray, and the only really radiolucent part of the valve is this upper ring. Now, be aware that this picture is taken outside of the body. Once you're looking at the valve through X-ray in the body with the ribs, the heart, the lung tissue, this fine line can be quite difficult to visualize. Also, as I'm sure you're all aware, but when we do a transeptal mitral valve, the orientation of the Sapien valve is upside down on the delivery system, so all the foreshortening will be coming from the top visually, and so it's quite important to make sure that you're happy visualizing this marker to make sure that your valve deployment is correct. As you can see, there's no real risk of LVOT obstruction in this case. Our neo-LVOT measured a 181, and there's a post here from the surgical valve that we traced around. But one of the key things is that looking at the valve specifically, the leaflets only end here, so this area which we are thinking is going to be blocked by with our neo-LVOT won't actually be. So it's important to take valves, the specific surgical valve into consideration. We actually tried initially to go transeptal and antegrade, but a 125 millimeter MPA did not reach the pseudoaneurysm, so we went retrograde through the aortic valve. The pseudoaneurysm was wired with a glide advantage, and we advanced the 5 millimeter MPA catheter into the pseudoaneurysm. And here's an injection through the pseudoaneurysm so you can visualize it. The neck of the pseudoaneurysm was 4 millimeters, so we used the 6 millimeter AVP2 plug, and the 6 millimeter, the AVP2 plug has two discs with a central cylinder, and the cylinder sat nicely within the neck, and one of the discs at the origin of the pseudoaneurysm. This is a picture of the detachment, but what is key to notice is the hang-up of contrast in the pseudoaneurysm here. The blood flow has been significantly limited, and this is going to clot, and this will help essentially isolating the pseudoaneurysm from the circulation. We then went on with our valve-in-valve using a Sapien 3 Ultra. The Ultra valve was useful in this particular situation because the balloon didn't have to be pulled back into the valve before deployment. Now, you'll notice a very slow and deliberate deployment, making sure that we are precise with landing of the valve. All the foreshortening, as mentioned, occurs from the inflow in this case. You can see the shape. So we post-dilated the valve of a 22 millimeter true balloon, and here we actually inflated to 16 atmospheres. Now, the inner stent diameter is 21, so we went one over for 22 true. And although fracture has been described, you can see by the recall that it's unlikely that we fractured the valve in this case, and we just expanded it. This is a picture looking down the barrel of the valve, showing quite good expansion. Here's our AVP2 plug blocking the pseudoaneurysm. And potentially I shouldn't be showing this, but here's incorrect placement of the pacing lead, which is actually on the free wall. Ideally, this should be pointing towards the septum. So just to compare the imaging, we managed to follow up the patient and get a follow-up CT, and this is the pseudoaneurysm seen beforehand. And this was actually at 6 weeks, and you can see complete exclusion with no contrast into the pseudoaneurysm after. And here's a 3D volume rendering. Pseudoaneurysm is now excluded with no contrast flowing there. And in the last 15 seconds, we'll just have a quick look at the hemodynamics. Now, with mitral valve and valve implantation, there's definitely a risk for neo-LVOT reduction and obstruction of the LVOT, and you can see even at 6 months we do not have any significant obstruction. Thank you very much for listening.